Thank you for inviting me to speak at the Brazilian Emergency Medicine Conference. My name's Ken Milne, and you can find me on Twitter at the SGEM. I am going to attempt to critically appraise 10, that's right, 10 recent research papers in only 15 minutes. There will be one slide for each article, and I'll give some background information about the topic, the study design, the key results, and a bottom line. There will also be a link to the original article and the Skeptics Guide to Emergency Medicine podcast for a deeper dive. So buckle up, Brazil, because here we go. Number 1. There were a couple of small studies about 20 years ago claiming efficacy of therapeutic hypothermia in out-of-hospital cardiac arrest patients. This treatment was tested in the original Targeted Temperature Management, or TTM trial, and they compared 33 degrees to 36 degrees and found no statistical difference. TTM-2 was a multicenter, randomized, unblinded trial of 1,900 adult out-of-hospital cardiac arrest patients who were cooled to either 33 degrees Celsius or compared to keeping the patients less than 37.5 degrees Celsius, or normothermic. Key result? No statistical difference in death from any cause at 6 months. Bottom line? You don't need to cool these patients. 2. Hyponatremia is one of the most common electrolyte abnormalities in clinical practice. We've been warned, don't correct hyponatremia too quickly or risk the horrible condition of osmotic demyelination syndrome, or being locked in. The mantra has been, go slow and keep it low. The SALSA trial looked at adult patients with moderate to severe symptoms of hyponatremia and a serum sodium of less than 126. They compared rapid intermittent bolus, which was given every 6 hours until a targeted serum sodium level was achieved and symptoms were relieved, and this was compared to a slow, continuous infusion group. Key result? No statistical difference in the incidence of overcorrection of serum sodium at any given period up to 48 hours. Bottom line? Go rapid or go slow. The speed of correction does not seem to matter, but be careful not to overcorrect. Number 3. Dr. Paul Marik got the critical world all excited when he claimed a vitamin C cocktail of vitamin C, hydrocortisone, and thiamine as a possible cure for sepsis. His position was in part based upon a retrospective before and after study he conducted at his hospital. The LOVIT Trial, and I love it, was a multicenter, randomized, placebo-controlled trial of almost 900 adult patients admitted to the intensive care unit with a suspected infection and receiving vasopressor therapy. They compared intravenous vitamin C given at 50 milligrams per kilogram every 6 hours and up to 96 hours versus a placebo. The key result? The vitamin C group did statistically worse for the primary composite outcome of death or persistent organ dysfunction. There was not a statistical difference between the individual components of that composite outcome. Bottom line, the juice is just not worth the squeeze when it comes to vitamin C. And this agrees with multiple other randomized control trials that have looked at this issue. Vitamins, ACTS, or Victus trial. 4. Many of us were excited about the study showing the efficacy of tranexamic acid, or TXA, for epistaxis. This excitement was recently tempered by the NOPAC trial. They took almost 500 adult patients and randomized them if they still had epistaxis after 10 minutes of direct pressure and 10 minutes of packing with a topical vasoconstrictor. The intervention was a cotton wool dental roll with 200 milligrams of TXA that could be repeated once. This was compared to a placebo control of a cotton wool dental roll soaked in sterile water. Key result: no statistical difference for patients getting anterior packing. Bottom line, be skeptical about the efficacy of TXA for epistaxis. There may not be any advantage to using TXA in these patients. 5. Antibiotics are recommended for school-aged children diagnosed with community-acquired pneumonia. However, how long should they be treated is an open question. The SCOUT CAP trial was a randomized, blinded, placebo-controlled, non-inferiority trial that looked at 5 days of amoxicillin plus 5 days of placebo and compared to 10 days of amoxicillin in 281 children diagnosed with community-acquired pneumonia who were well enough to be discharged for outpatient management. Key result: no statistical difference in the 5-day course of antibiotics compared to the 10-day course of antibiotics. They had similar efficacies, similar adverse events, while reducing antibiotic exposure and antibiotic resistance. Bottom line, short course of antibiotics for outpatient management of pediatric community-acquired pneumonia is very reasonable, and it agrees with previous trials like CAPIT and SAFER. And guess what? Rumor is Dr. Cooperman from the PCARN group are now working on a trial looking at 0 days of antibiotics in these children. Stay tuned. 6. There has been a long-standing debate about which intravenous fluid is the best for volume resuscitation in critically ill patients. The BASICS trial looked at over 10,000 adult patients admitted to the intensive care unit needing fluid expansion and had a risk factor for acute kidney injury. This was a double-blinded, factorial, randomized clinical trial conducted at 75 ICUs in Brazil. Patients were randomized to either Plasma-Lyte or 0.9% saline infused either fast or slow. Key result: no statistical difference in mortality at 90 days. The bottom line: balanced solutions are not necessary for most adult ICU patients. Administration of modest volumes of Plasma-Lyte or normal saline, either fast or slow, did not seem to influence 90-day mortality. The PLUS trial was published this year by Finfer et al. In the New England Journal of Medicine, and it confirmed the findings of the BASIC trial that balanced solutions were not necessary in these adult ICU patients. 7. The pre-hospital use of fluids for trauma resuscitation has been investigated in a number of studies in recent years. The REFILL trial was a multi-center, open-label, single-blinded, randomized control trial of 432 adult patients with traumatic hemorrhagic shock. They compared blood products versus 0.9% saline. Key result: no statistical difference between the two groups for the primary composite outcome of mortality or failure to clear lactate by 20% within 2 hours. Now, they did break apart each component of the composite outcome, and they also were not statistically different. Bottom line, pre-hospital trauma patients do not need a refill with blood products. The results of this trial do not justify the expense and logistical difficulties associated with the use of blood products by emergency medicine services in adult trauma patients. The refill trial results were similar to the COMBAT trial, which also did not show a mortality benefit within 28 days, but it is in contrast to the PAMPER trial. 8. The American Heart Association guidelines recommends performing immediate coronary angiography for out-of-hospital cardiac arrest patients with a suspected cardiac etiology of arrest and ST elevations seen on ECGs. The TOMAHAWK investigators did an unblinded randomized control trial of 554 patients with an out-of-hospital cardiac arrest who had return of spontaneous circulation, but no ST elevations observed on ECG. They compared immediate angiography to a group that were admitted to the ICU and could get delayed or selective angiography. Key result: no statistical difference in all-cause mortality at 30 days. So the bottom line, there's no need to rush these patients to the cath lab. There appears to be no clinical benefit taking these adult patients with out-of-hospital cardiac arrests who have ROSC and no ST segment elevations immediately to the cath lab. 9. Large chest tubes are traditionally used for the treatment of patients with traumatic hemothorax, but are they necessary? This was a multi-center, non-inferior, unblinded, randomized trial of almost 200 hemodynamically stable adult patients suffering traumatic hemothorax or a hemopneumothorax requiring drainage. They compared a small, which was a 14 French pigtail catheter, to a large bore, a 28 to 32 French chest tube. Key result: small tubes were non-inferior to large tubes. Bottom line, bigger isn't necessarily better. It's reasonable to offer a small pigtail catheter instead of a large bore chest tube for the evacuation of traumatic hemothorax in a hemodynamically stable patient. 10. Buccal fractures of the distal radius are the most common fractures seen in children. Despite being a common injury, they are often managed differently. The FORCE trial was a multi-center, randomized, non-blinded equivalence trial of almost 1,000 children aged 4 to 15 years of age. Key result: a soft wrap was equivalent to rigid immobilization for pain on day 3. Bottom line, wrap them up. It's very reasonable to treat distal radius buccal fractures with a soft bandage, immediate discharge, and these children don't routinely need follow-up. And this agrees with other studies done over the past couple of decades. So there you go, 10 papers in under 15 minutes. However, this is only the evidence. You will still need to apply your good clinical judgment. I'm not telling you how to practice clinical medicine where you work, only what the published literature reports. You will still need to ask the patients, what do they value? They may have different preferences than the patients in my community. And these are the 3 pillars of evidence-based medicine. There is the evidence, which informs our care, guides our care, but should not dictate our care. We still need to apply our good clinical judgment and then ask the patients what they value and what they prefer. And of course, always remember to be skeptical of anything you hear, even if you heard it from me. Thank you very much, and I'm happy to take questions.